Hashimoto's often starts during the 3 Ps: puberty, pregnancy, and perimenopause. That is why I am so excited for this interview today. I have Dr. Grace Charles. She is a naturopathic fertility doctor, and she is going to talk to us all about Hashimoto's, autoimmune problems, and pregnancy and fertility in general. This is probably one of my favorite interviews that I have done yet, and I am so excited for you to listen. As far as the good, better, best gut stuff, we'll come back to that next week. Welcome to the Health with Hashimoto's podcast. This is where you will find clarity and simple, sustainable strategies to feel better. I want to help you figure out your root causes. My name is Esther Yunkin. I am a registered nurse. I know how exhausting it is to live with fatigue, brain fog, and the ups and downs of Hashimoto's. And that is why I'm here. I'm here to cut through the confusion and to give you practical steps that support your body, calm your immune system, so that you can regain your energy and feel like yourself again. I have Dr. Grace Charles here with me today. She is a naturopathic fertility doctor who helps women uncover the why behind infertility, especially when thyroid or autoimmune issues are part of the picture. After years of watching women get told, just keep trying, or pushed straight into IVF, she developed her root cause fertility formula, which is a systematic approach to finding and fixing what's really going on. She has helped hundreds of women conceive naturally by addressing the underlying issues like Hashimoto's, PCOS, and nutrient deficiency before jumping into expensive treatments. Dr. Grace, welcome to the Health with Hashimoto's podcast. Tell us a little bit about yourself.
Oh, thank you so much for the great introduction. I think you said it. My job is to help women and couples understand why they haven't gotten pregnant naturally before investing in IVF. I work a lot with women who have the diagnosis of unexplained infertility, and my deliverable is getting them an explanation for what's going on and why it hasn't happened yet. And I'll tell you, for a lot of those women, it's Hashimoto's.
Yeah. So on the podcast before, I've mentioned that a common time that women develop Hashimoto's is the 3 Ps. It's puberty, pregnancy, and perimenopause. Being that you are a fertility expert, will you talk about that pregnancy piece and the hormone changes and why Hashimoto's develops, and then what can we do about it?
Absolutely. And it's something that I see in my practice really frequently, especially with women who are trying for their next child. So we call that secondary infertility, when baby number one was just no problem. And then 3 or 4 years later, couples are wondering why baby number two hasn't come. And it's often because of that second P during pregnancy, these hormonal shifts that change the thyroid cascade, change the way the immune system is working, and can trigger Hashimoto's. We see it especially, I catch it often in the postpartum period. When women are having especially difficult postpartum periods, that's when I'm really pushing them to say, make sure we're getting the thyroid antibodies tested, because this is the time that we're going to see it. And then the effects of those antibodies and the effects of the thyroid dysregulation, especially if it hasn't been caught, can change fertility altogether. And I'd love to walk you through the ways that fertility and thyroid really overlap.
Yeah,
But
let's do that.
We can kind of take that one at a time, because it's a big topic.
It is very big.
There are 3 main ways, and the first way is, and going a little bit of biochemistry. I hope that's okay with your listeners. When TSH is elevated, and we all know about this one. When TSH is elevated, something called TRH, thyroid releasing hormone, is going to pick up on the fact that thyroid function is low on downstream, and it goes up. And when TRH goes up, something called prolactin goes up. Prolactin is a hormone that, when that's up, it's going to suppress FSH and LH. And those are really important hormones for fertility. Those are the ones that ripen the egg and release the egg. They're the brain telling the ovaries to ovulate. So when those are low, we see poor ovulation because the egg hasn't ripened sufficiently and we're sending out kind of an underripe egg, or the ovulation doesn't happen at all. So we see anovulatory cycles. So this pathway, this high TSH causing poor to no ovulation, that gets caught pretty frequently by conventional medicine, because that's when somebody goes to their gynecologist and says, I haven't gotten pregnant and we've been trying for a year. That's one of the tests they will run. They will run TSH. So that one usually gets caught. If TSH is above 2.5, the gynecologist says, well, here's some thyroid hormone to correct this. And sometimes that's That's all it takes, because that's the pathway that is being affected. Now, another way that thyroid can affect fertility is that there are thyroid receptors inside the follicle. There are TSH receptors and there are thyroid receptors. The thyroid receptors are for a thyroid hormone called T2. We don't talk about T2 a lot because we can't test for it. T3 turns into T2. We can test for T3. So we assume if the T3 is robust, is if there's enough T3 there, then we're going to have to assume that there's enough T2 there. But conventionally, we're not testing for T3. So if you have good TSH and maybe they've checked your T4, T4 is good too, we're not going to catch this low thyroid in the follicle. And that thyroid is very important because it also helps the development of the egg. The right amount of thyroid getting into the follicle and stimulating the ova, then we're going to, again, have poor quality ovulation. And then the third pathway is more specific to Hashimoto's. So there are those TSH receptors and thyroid receptors inside the follicle. And there's also tons of TSH receptors in the endometrium. So if there's any sort of antibodies, autoimmune at work, attacking these thyroid hormones, attacking the thyroid hormone receptors, attacking the TSH receptors, I mean, that's what Hashimoto's is, it's happening in the wall of the uterus where the zygote goes to attach and become that pregnancy. So we'll see in women with Hashimoto's, because of the inflammation and the autoimmune activity in the wall of the uterus, that we're seeing miscarriages or just infertility in general. So those three columns are really what we want to make sure we're looking at all three when it comes to thyroid and fertility.
Wow. I didn't know a lot of that. Thank you for explaining it. And it's like I read about pregnancy and the chance of miscarriage and infertility related to thyroid, but nobody has explained it in that way. So thank you very much for explaining that to my audience. I
Of course.
appreciate it. Yes. So what would somebody do if, number one, they're not getting pregnant? And then number two, if they actually get pregnant, but they're miscarrying, would that be the same thing that both people are going to do? Or are there two different approaches?
Well, I think step one applies to everyone, and that's get the full thyroid panel done, right? Let's find out what the TSH is. That's super important for that first column. Let's find out what the free T4 and the free T3 is. Very important for egg development. And let's run all the antibodies and see what the status is there. Now, your listeners, I think they already know they have Hashimoto's, so this isn't a big reveal to them. But knowing your antibody numbers can be very helpful because it gives us a starting point, a baseline of how we're going to go down from there and pull those antibodies down. I think there's kind of two parts. There's so many parts to Hashimoto's care, but there's two parts to Hashimoto's thyroid care, which is one, let's get the numbers right. So let's use what's available to us to get the TSH below a 2.5. I like it a little bit below a 2 for my fertility patients. We keep it really tight. We want to get the T4 above a 1. We want to get the T3 T3 well above a 3. So we prescribe or support until those numbers are right. And then we have to do the work of how do we get the antibodies down. For a lot of women coming into my clinic, Hashimoto's is a big reveal diagnosis. I didn't know I had this. Nobody's ever checked. But even if somebody comes in with the diagnosis of Hashimoto's, my job then is to go even further and say, well, why do you have Hashimoto's? What's the root cause of the autoimmune disease? Something is telling the immune system to go ahead and attack your own body. So we have to identify that and treat that. And if we can get to that level of work, we will see those antibodies go down and fertility improve.
Oh. So the main thing I'm hearing is you could do something. If you're
There's so much to do. And you guys speak about this on your podcast all the time, of all the different systems that we need to consider when we're looking at Hashimoto's. Because as I said, the women who are listening, they have Hashimoto's. They know that the thyroid is an issue, the immune system is an issue. And they know that there are so many other places in their health that they can start improving that will have this effect on improving the thyroid and the immune system.
Yeah. So let's go back to when somebody is pregnant,
Mhm.
maybe first pregnancy or second pregnancy, and developing Hashimoto's. You said you often find it in the postpartum period. What would be things that they're looking for, symptoms that they're observing that would tell somebody, I need to pay attention to my thyroid? This might be happening.
What I see the most is scary thoughts postpartum. And that's an odd answer, I know, and that's what I've seen clinically. I don't have a ton of studies to back this up, but postpartum anxiety, these are kind of blanket terms, and they can they can include a lot of symptoms. But specifically, what I'm looking for is hearing somebody say, I worry about the baby so much. I worry about the crib breaking in the middle of the night, or what would happen if I drove off the road, or the dark thoughts that can come along with postpartum anxiety and depression. So that for me is a real red flag symptom. But anything in that realm of not being able to sleep, and that's a tricky one because baby is why you can't sleep usually. But sometimes baby's sleeping and you're not. That's a symptom. Feeling grumpy, feeling tired that can't be explained by your lack of sleep, feeling like just like the mental fog. Those are things we're looking for.
Oh, as you're talking through that, I'm thinking back to my third baby
Mhm,
postpartum. I'd never had any problems driving, and all of a sudden postpartum him, I had this irrational fear every time a semi was driving by me, especially, like, passing me or going the same way. Like all of the physical symptoms of anxiety, semis, I just had this irrational fear, and after our 3rd baby, I had my first miscarriage. I was not diagnosed with Hashimoto's at that time, and so I wonder if maybe during my 3rd pregnancy, that was it for me. I have
that was your second P.
Yeah. Yep.
Mhm,
And, in talking to my husband and on this Hashimoto's journey, learning all about it, doing, 170, 200 podcasts, like, I've never been able to pinpoint when I probably got it,
mhm.
but listening to your stuff, I'm like, maybe that was it."
Could be, and that's certain like, if a friend tells me that someone who's not in my patient base, right? If somebody mentions that kind of thinking, I'm like, "Go to your doctor, make them test your thyroid antibodies. Don't stop until like, don't take no for an answer," because
Right.
that's usually what it is. The TSH is way off the charts, and there are antibodies there.
Yep. Wow. So tell us about the root cause fertility formula that you've created because it helps women find out why they're struggling to conceive, right?
Yes. So, what what I really want to make sure women and couples understand is that we can't be throwing treatments at them until we have a diagnosis. That's good medicine, right? We diagnose and then we treat. And especially women who are given this diagnosis of unexplained infertility, that's not really a diagnosis. We haven't figured out your diagnosis yet. And they're being told to go to IVF. And that's a really big treatment. So going into a big treatment without an adequate diagnosis is step one. So we've got to get these patients a diagnosis. And sometimes it's Hashimoto's. Sometimes it's subfertility in the male. Sometimes it's endometriosis. I mean, there's all sorts of reasons, but we can find it and we can use functional testing to really get to the bottom of what's keeping them from getting pregnant or what's keeping them from staying pregnant. And then our job, I'm not going to say it's easy, but once we have a diagnosis and 3 or 4 things that we need to be treating, then it all kind of falls into place. Well, gosh, you've got a really big imbalance of your gut microbiota. We need to fix this. We need to treat your gut. Or you get 3 minutes of deep sleep a night. So you're missing this opportunity to heal when antioxidants are the most active. That's between 10 p.m. and 2 a.m. You're not getting any deep sleep there. So you're not really accessing this very important step of keeping your reproductive health. So once we can pinpoint the issue, then we take it step by step and treat until the fertility markers improve and patients are able to get pregnant naturally. And if not, they're really in a much better place, much more successful IVF outcomes.
What are some of the most common things that you see with your patient population that are easy to fix?
That's a great question. I don't want to sound glib here because I know what a journey Hashimoto's is, but I do find that once it's identified, once we can get to the root cause of Hashimoto's, once those factors are identified, it's fairly straightforward to take or to fix. It takes time and it takes commitment, but th- there's a path. I mean, there are steps we can do to heal that gut, to increase that deep sleep, to do all the pieces here. So I think that's one that I enjoy working with because I know I'll bring those antibodies down and we'll have success. PCOS, it's another really nuanced diagnosis that is spectrum diagnosis. You can have low levels of antibodies with Hashimoto's and high levels of antibodies, and symptoms don't necessarily need to match those levels of antibodies. Similarly with PCOS, the symptoms and the lab presentation can be a really wide spectrum of presentation. People with PCOS can all look very different from each other from the outside and from the labs from the inside. So that's another diagnosis that when that's what we're working with, it's okay, we're going to work on this insulin. We're going to get rid of the inflammation. We're going to help you lose a little bit of weight if that's necessary. And we're going to get the brain and the ovaries talking to each other again. So those are a couple diagnoses that I particularly love to work with because I have a pretty strong path forward with them. And the other one is male fertility. And this is not easy to treat because it's difficult to get the men on board, unfortunately. But it sure is easy to diagnose because with a semen analysis and some good blood work, we know if male factor infertility is an issue.
Right. For a woman with Hashimoto's who's trying to get pregnant,
Mhm.
if she comes to see you, what is a realistic timeline for her to expect? Like, we want microwave results. We want to go see you, and then the next cycle we're pregnant.
We want the baby
What's
yesterday. Yeah.
right? What's a realistic timeline?
And I'm so glad you asked. I work almost exclusively, not on purpose, with type A patients, women who really know what they want and are not used to not getting exactly what they want because they're they're good at their jobs. They're good at making their dreams into realities. So when infertility is on their plate, it can be overwhelming to my type A patients. And the timeline is probably the hardest pill to swallow. I would say 6 months is reasonable. 6 months of care, of treatment is probably a good average. Sometimes it takes up to eight if those antibodies are really stubborn. But if someone's really on board with the treatment plan, they're willing to make some dietary changes, they're willing to make room in their life for better boundaries, better self-care, we can usually get it done in about 6 months once we know what we're working with.
Awesome.
And that's
Very
what's important, though, is that we're not trying during those 6 months, that they are taking a break from it. And that's very important for a lot of reasons, right? Because it's when a woman isn't getting pregnant every cycle, there's no disconnecting from that because every time they get a period, they're reminded. Every time they have a symptom of PMS, it could look a lot like an early pregnancy symptom, they're reminded. Every time they ovulate, every time they're gearing up for ovulation, it's unending. So taking them off of that roller coaster can be very helpful for their mental health. But we also don't want the pregnancy to end in a loss. We want the pregnancy to be the baby, the healthy baby. And for Hashimoto's, we don't really, I try not to give patients the green light to start trying again until we've really gotten to the root cause and healed a lot of these systems. So it's a 6 to 8 month timeline.
Okay. That is very good to know. So tell us how people can work with you and how they can connect with you.
Oh, great. Yes. You can connect with me with a free call. I'll talk to anyone. Talk to anyone. I love talking about fertility. I do it all day long. And if you hop onto my website, drgracecharles.com, drgracecharles.com, you can just click a link and get on my schedule for a free call. That's mostly how I reach out to people. I'm not super active on social, and there's a reason for that. And I know my future patients are there, but I really don't. I really don't love it. I don't want my patients there, so I don't do a ton of outreach via social. So my old fashioned approach is my website.
That's awesome. And did you have a freebie? I
Oh
can't
yeah,
remember
yeah,
what you
yeah.
said.
Of course.
Okay.
If you type in drgracecharles.com/today, you'll get a list, really detailed list, 10 things you can do today to improve your fertility. And it goes through all sorts of great ideas that you may not have thought about yet.
Perfect. I will have that link down in the show notes so everybody can just scroll down and click. If the listener is like, this was a lot of information, all fantastic, but I'm a little overwhelmed, what is one thing you want her or him to remember from our conversation today?
Great question. And it is overwhelming. And it's a lot of biochemistry that you don't need to know necessarily. I think the one takeaway is that we can treat it. And if you are someone with Hashimoto's who's struggling to get or stay pregnant, there's hope for you, because if we can get to that root cause diagnosis of what's worsening the Hashimoto's, we can heal those systems. We can heal your reproductive function, and we can even like reverse age things and get you back to fertile. So if you have Hashimoto's and you're struggling with pregnancy, there's a path forward for you, is what I'd like you to know.
This podcast is for informational and educational purposes only. Please discuss any changes with your trusted healthcare provider. To take your next step, join our school community and explore the courses available there. You do not have to figure your health out alone. So that is school, SKOOL.com, and it is the Health with Hashimoto's community. I'll see you next time on the Health with Hashimoto's podcast.